Okay. Can I have a pointer? Well, so just one minute before starting. So this is actually not a Bony Bankart. This is a very nice video in my opinion. And this video, so the history is, well, I operate normal people. I'm not a guy that operate top athletes and stars of the sports world, but actually this is a very famous athlete that happened to be sent to me in March this year. This is a 22-year-old guy who plays professional soccer. He used it to play in a famous team in Brazil, and he was sent to Ukraine, where he plays. He had a fall in January this year, and he dislocated his shoulder, but he had a lot of pain, and much more pain than usual, and a lot of pain in the biceps, in the bicipital groove. His MRI was really inconclusive, and we knew that he had a Bankart tear, but when we happened to operate him, he had much more than this. So this video is a nice opportunity for us to understand the diagnostic role of arthroscopy, how useful arthroscopy is and can be, and what about the decision making in so unexpected situations. And the video I'm showing step by step, because I think that for the audience it's going to be nice. So wait a minute. So okay, so once we entered, we could realize that the patient had a huge biceps tear here. So he had much more than a Bankart, but here we can see a long Bankart, but with a huge biceps tear. So now we're establishing the anterior portal just above the superior part of the subscap. Now we enter within the cannula, and as a sequence we passed the Prolene suture as a whip stitch in the long head of the biceps, just to hold the biceps, because in our opinion this is a case in which you don't have to refix the biceps. You have to solve the problem doing a tenotomy and a tenodesis. So we did a tenodesis very fast with an arthroscopic scissor, and now the tenodesis is done. And at that moment, we had two things to do: to fix the slap and the Bankart, and then to do an intra-articular biceps tenodesis. So here we can see a large Bankart. Here we can see the biceps. And then using a spinal needle, we established an anterosupralateral portal. And I always say that it's very important to put it in the most perfect position. In this case, we entered with a blade to open the capsule very delicately, very slightly. And I always use a mosquito, a Kelly device, to open the capsule. And then we in this case, we can use a Wissinger device or even a key wire as a Wissinger device. So here we started to prepare the anterior part of the glenoid, and to create a bony bed, a bleeding base. And it's very important that in arthroscopy you must never lose time, so don't stop to admire your work and go ahead. So now we are going to the upper part about 2 o'clock or 3 o'clock in the anterior surface, and then we change the portals, and for the superior portal, the anterosupralateral portal, we are just creating a bony bed in the superior part of the glenoid. So here we can see again that I was struggling with the camera just to enter the glenohumeral space, because the labrum was literally falling into the glenohumeral space. Another thing that I like to do a lot is to use a basket to remove about 1 to 2 millimeters of the articular cartilage, and Pascal Boileau, he really likes this too. And then at this moment we were treating the case as a standard Bankart. So now I am putting the first anchor. In this case, this is a BioMini Revo from Lymphatech. Unfortunately, it's mono-loaded. So using no special devices, but a simple bird beak, we entered from the very low part of the capsule. And in these cases, it's not easy to pick the suture with the bird beak. So using a suture manipulator, we pulled one of the legs of this suture to the bird beak, and in a retrograde fashion, we were passing the first suture through the very inferior part of the labrum. I use a Duncan knot, but it doesn't matter. You can use the knot you want as long as you fix it, but it's very nice to hide the knot in the other side of the labrum. Now I am putting a second anchor in the same way. This is a mono-loaded, I guess 3.0 or 2.9 absorbable anchor. Again, with a simple bird beak, we are passing always from south to north, from inferior to superior, and in a retrograde fashion, we are pulling the suture out of the anterior cannula and tying the second knot. So now the knot is being tied. At that moment, so we changed the cannulas, and then for the superior cannula, we were fixing this lap part exactly in the same way. So now we are putting a third 3.0 absorbable anchor, and then we would just have to pick to pull one of the legs out of the shoulder and tie for the anterior superlateral portal, the third anchor. At that moment, so we tested the construction here, but this is an elite sports athlete, so we decided to put one more anchor here because we think that it's very important to distribute the tension over the labrum. So now we are putting one more anchor, something about 2 o'clock much probably. I always use a hammer to fix it properly. So this is the final anchor, and using nothing special but a simple bird beak, we tied the fourth knot. So here we can see that we recreated a very good bumper sticker from 5 o'clock to the midnight hour. And at that moment, so I always like to invert the portal. So I am entering now with the camera in the anterior portal just to check that I have nothing in the posterior portal, but there was no clinics and there was nothing in the in the MRI, but still I like to see, and expected there was nothing, so I'm coming back to the posterior portal, and now I have to do the intra-articular biceps tenodesis. So here we can see the biceps, and this is much like a subscap repair. So using a burr, we created a bony bed in the lesser tuberosity, and here we don't have much space. The movements must be very slow and in a delicate fashion. Now I'm entering with a 5.0 metallic double loaded anchor to perform the intra-articular biceps tenodesis. So I am putting it in the lesser tuberosity. It's very important to insert the wall cannula. Now we will see some bubbles here, meaning that it entered the metaphyseal bone, and here it's very important that, as I said in the morning, it's very important to separate the sutures, not to make a mess with them. So the blue sutures are in the anterior superior lateral portal, and then for the anterior portal we entered with nothing but a simple bird beak to perform a biceps tenodesis. So then in a retrograde fashion, we are picking just one leg of the blue sutures and passing these in a retrograde fashion through the anterior cannula. And now it's very important to separate again the sutures. So we are entering through the anterior superlateral portal to pull that leg of the blue suture out of the anterior superlateral cannula, because I always say you cannot make a mess with this suture. So this knot is ready to be tied, but because of lack of space, we decided to pass the other suture first. So again, we are separating the sutures, and we pulling with a simple grasper the biceps through the anterior superlateral portal, and through the anterior portal we are passing with nothing but a spectrum device. This is from Linvatec, so no special material. So we used a grasp, and in a retrograde fashion we passed the suture through the anterior superlateral portal, and then we would just have to pass the other leg of the wide suture and put it in the anterior cannula. So now we are tying the first knot through the anterior superlateral portal. This is a sliding Duncan knot, and once the knot was tied, it has to be cut. And now we are tying the second knot through the anterior cannula. This is a sliding Duncan knot too, and here we can see the subscap, and then the knot was tied. And this is the final construct, in which we can see here that the biceps was very well fixed in the lesser tuberosity as we internally and externally rotate shoulder. And here we can see the subscap, and this is the final construct of the labrum, very well fixed, the labrum, the Bankart, and the slap itself. And so the surgery was finished. And that's it. So I think that the nice thing of such a video is to show that arthroscopy has a very big diagnostic role, much more in cuff tear than in standard Bankart tears. But sometimes you see situations like this, an unexpected biceps tear, and there is a school that would say refix it, but I think a lot like the French surgeons, that the biceps is a mess, and in such case, me and my partner, we had no doubt that a biceps tenodesis would be the best solution. And to fix this, there is an order of steps. So what are you doing first? The biceps tenodesis or the Bankart of this slap? And you have to have organized concepts and organized steps to make the surgery work. Fixing this Bankart was very easy. Fixing the slap was easy. Doing the biceps tenodesis was not easy, even for us that have been doing this for 10 or 11 years. But some guys use it to say that a biceps intra-articular tenodesis is very hard, and it's not. You can do it. Actually, there are nowadays more than 20 ways of making a biceps tenodesis. You can make a soft tissue in the subscap, even in the conjoined tendon, in the supra, in subpec. But in this case, we thought that as the pathology was not in the biceps itself, but in the biceps root, it would be enough to do this in the lesser tuberosity. The surgery was 12 of June, and this patient is already back to Ukraine playing soccer professionally. And that's it. Thanks.
Any questions or comments on that?
Sergio?
Yes?
Nice robust repair of the labrum. Nice robust repair of the labrum.
Good.
But why would you not put the biceps in the groove rather than in the lesser tuberosity?
Because this is a very nice question, and we could even, I'm going to answer you, but then you could even answer, make me another question. That is the fashion, the hit of the moment in the United States. That is to do a biceps tenodesis in the groove with an interference screw. So the thing is, I am always in ViewMedi, and I am reading the discussions a lot, and I have seen so many guys in the United States saying that, oh my God, my patients are having so many pain in the groove with the bicipital tenodesis inside the groove, especially with interference screw. Even Snyder is making some comments that honestly I was afraid. I was afraid. So I have a very good experience. I have no experience with this technique, but I would feel safe to try. But I have a good experience fixing subscaps. So if someone, if you can do a subscap repair arthroscopically, this is much more or less the same. So the same angle of approach. You put the anchor in the same way, and I would be sure that he would have no pain. And I have been seeing no papers, but a lot of comments of guys saying, "Oh my God, I'm having so much trouble," and this guy had absolutely no pain in his post-op, and also there are many reports that you can have a frozen shoulder after you fix a slap, and I was sure that if I did a tenodesis, this would not happen.
No, I think the tenodesis this is
was well indicated.
Perfect.
Sure.
Now correct me if I'm wrong, but the reason United States is moving to a sub-pec tenodesis
Yes.
is because the biceps in the groove leads to impingement in that position
I've-
because you've got
I've-
a proud tendon.
I've been reading
which is
this.
swollen and swapping in the
Popping.
the groove. But even your lesser tuberosity insertion is also going to keep a prominent long enough biceps in that manner. So I'm not
Condemning.
Yeah.
Yeah.
I mean, it's an interesting thing. First time I've realized that you
Okay.
put a long enough biceps in the
Okay.
lesser tuberosity.
Okay.
When I do the subscap repairs, I just do a soft tissue with the biceps.
Oh,
and subscap.
I understand.
That works nice.
Okay.
I'm just wondering, because some of the surgeons marry the long enough biceps to the cuff, then that remains prominent and causes impingement.
I know.
So from
So,
the same point of view,
I under-
it's not.
I understand, but first of all, think with me. He's not a volleyball player. He's a soccer player. So he's playing with his legs. But before operation, when he was running, he felt that his shoulder was dislocating all the time, and he had a lot of pain. And his pain is gone. But there are two guys in the United States that I like a lot. Dr. Richard Ryu, and the Indian guy, the famous Indian guy, Sumant Butch Krishnan, and I am a declared fan of him. I think he's fantastic. And there are two lectures, one from Sumant, one from Richard, saying that if you want to have the best results, do a sub-pec tenodesis. How many have I done? Five, all with interference screws, like in the tibia, in ACLs. I have had some problems in the first, so if I can share some ideas with you. First, use a retractor to pull the pec superior, because in one case when I pulled the tendon entered all, and I was in the myotendinosus part, and when I put the screw, it was cut.
Wow.
And then I had to make a salvation procedure in the pectoralis major. The patient is fine, but I was very frustrated. And the other one, you have to do, I am not a knee surgeon, but you have to do the hole in the same size of the screw. This may be obvious for knee surgeons, but for me, I had some trouble in the first cases. So now, what have I learned with 5 cases? It's not much, but it's something. You need nothing but a number 7 screw. And another tip is, don't come in this way. You come from medial to lateral to avoid the radial nerve posteriorly. And one thing that I do is what my partner learned with JP Warner in the United States. I guess everybody here knows that in the ACL kit you have a key wire with 4 holes in the end. So we make a whip stitch on the biceps and we pass those sutures in the key wire with 4 holes, and the key wire is here, and then we pull it, and then we pass the screw, and everything goes fine. And all my patients, I have 2 patients, 42-year-old guys, strong guys, they are making biceps on the gym with the subpectoral tendon. This is absolutely painless. So they say, if you want to get out of any trouble, but in this case, as he's not a thrower, I thought everything would be fine. But hopefully 8 years after, if he was in pain, I would already know. So hopefully he's fine. But I think that doing the tenodesis intra-articularly is a possibility, and my idea was to show it. Okay.
One more tip to your subpec major.
Yeah.
Ricky Ryu says, don't drill the opposite cortex. They've had fractures.
Yeah. Just one complication I had, and I don't feel bad about telling everybody. It was my second case. I drilled the two corticals, and when I passed the screw passed it to the posterior part of the shoulder, and I said, oh my God. I'm going to have a long incision, and I'm going to find it in the middle of the radial nerve, and I'm going to have a heart attack in the middle of the surgery. So what did I do? I left the screw there. Hopefully it's not metallic, but it's absorbable. I'm not sure if this is going to be absorbed in the middle of soft tissues, but it's not appearing in the X-ray anyway. And what did we do? We did a second hole, and we used a Vicryl needle, and we used the Vicryl suture as a whip stitch. So we passed the long head of the biceps through the 2 holes, and then I suture it in itself, and the patient is fine. But and then my friend saw a discussion in Vumeri with someone saying that we should only make the hole in the anterior cortical. But then I started to think, so how am I passing the tendon through one cortical only? So I'm still learning this. But if you have done, nice.
Doesn't matter. Just
Okay.
the tendon and lock it up.
Okay.
Works best.
Okay.
Thanks very much. I think we'll time
Okay.
to move on.
Thanks a lot.
David Strategy to talk to us about the overthrowing